tobacco and drug addiction in the country, and we will also be talking about the epidemic of road traffic accidents that Sri Lanka has been witnessing for several years now. Before we get started on our first topic of the day, which is suicide prevention, a reminder to our viewers at tuning in today that Sri Lanka has a network of mental health advocates who are ever ready to assist you or a loved one whenever they need it. Let me quickly put up those hotlines for you. The National Institute of Mental Health has a 24-hour toll-free hotline, which is 1926. There is the CCC line, which is also a 24-hour hotline, which is 1333. And you have the Sumitrio, Sri Lanka Sumitrio organization. Their number is 011 269 6666, and it's functional from 9 a.m. to 8 p.m. Thank you very much for joining us on the show this evening. Let me quickly introduce our panel of guests to you. On my left, we have Professor Indika Karunatilaka, who is the president of the Sri Lanka Medical Association. Thank you very much, Professor Karunatilaka, for joining us this evening. We're also joined this evening by Dr. Anula Wijayasundara, the consultant physician. Thank you very much, Dr. Wijayasundara, as well. And Professor Samudra Katriarachchi. She is the chairperson of the Suicide Prevention Committee of the Sri Lanka Medical Association. Thank you very much, Professor Katriarachchi. And to ask the questions that matter, I'm joined by Deshan Gonawala, who is our solo inquisitor this evening. Thank you very much, Deshan, as well. So without further ado, let's get into our three topics of discussion. Professor Katriarachchi, as the chairperson of the Suicide Prevention Committee at the Sri Lanka Medical Association, I'd like to start with you. Recently, as well, last week, the SLMA, your committee actually, presented a report to President Gotabaya Rajapaksa on suicide prevention in Sri Lanka. If you could, for the viewers, very briefly, explain to us what the crux of this report was, what were the key areas of focus, and what were the recommendations that were made to the President?
Thank you, Nadeem. Suicide had been a problem in Sri Lanka for a long time. Though people talk about it, one person dying at a time, and then people talk about it and then forget about it. But this issue is a complex and multifaceted problem which has social, economic, educational, mental health, mainly components in it, maybe political as well. So I think that Sri Lanka had always had a high rate, probably due to cultural aspects that we consider probably that another life and then sacrificing life for others or giving things. So it was there. But in 1960s, there had been a rather steep rise in suicides in Sri Lanka, mainly connected to Green Revolution, where the pesticides came into the country. So people who have a tendency to be impulsive or act on impulse at the times of distress took this poison. Because of the lethality, they died. And with time, it had been a big problem in 1995-96. If you can remember, when we were proud of Sri Lanka being the first in cricket, the same time we had this suicide, we were ranked the first in suicide rate in the world, whole world, which is this very saddest thing. So many things happened with this alarming situation, and one thing was that the formation of Presidential Task Force in Suicide Prevention at that time, which recommended few recommendations, and one of the main thing was to restrict the availability of pesticides and weedicides, import and sales, and then the other one is to remove the Kaneru trees. So that drastically reduced the suicide rate, especially among the rural areas. But along with that, I think probably gradually there was few other initiatives, like the civic commitment by the public, where the suicide was a criminal act earlier, and then it was decriminalized, and people talked about counseling for people who are in distress, and this counseling was available. And medical schools started teaching suicide, people who come to hospital with suicidal intention or without intention, but presenting to hospitals, and how to assess them, how to manage them. So the medical students were taught. Psychiatry was taught as a subject, finally a subject, along with all these things. And some research, especially in the medical area, there were a lot of research around the suicide among the psychiatrists and community physicians, various other groups. The people received some care, and the availability of hospital care, and then the road networks, even the small villages having three-wheelers to come to hospitals. So many variety of factors contributed, and then it became reduced. And probably there were other reasons, which I am not an expert on social and political aspects to talk about it. But I can say that Sri Lanka is particularly a different country, because usually in the world, when there's a war or when there's a calamity, rates go down. But in Sri Lanka, we had the high rates both together. So that is different. But there's a geographical variation as well. But we belong to, like Kerala in India, and Taiwan, Thailand, and Japan. Certain countries have higher rates for a long time. So, but whatever it is, that we have achieved a lot. And I think you will be happy to hear that in 1995 we were the highest. 48 per 100,000 people died at that time, but gradually there had been decline of the true suicide rate. We rely on police statistics, which is very reliable in our country, and by about 2016 it came down to about 16.6, and it came down again another 2% or 3% to 14.5 in 2018, so which is a good trend. But
Sri Lanka is currently, if I'm not mistaken, has the 29th highest suicide rate from amongst 157 countries for which
yes.
data is available. So this, because of this decline from 14.5. When you look at the contributing factors to people why this thing, what has been the change really between, let's say, 95, 96 and now? What has changed? What has contributed to the decline?
The major thing is that people use less lethal substances now. Still in the agricultural areas, pesticides and weedicide is a main cause, and it's very important to consider that in coming to the management. But like in any other country, especially in urban areas, young people and even people who are old people, they use substances available in the household, like medicinal substances or over-the-counter prescription tablets. So some of them take that, they think that sleeping tablets, they call it sleeping tablets, they are dangerous, or they might take it, but then they don't die because of that. But some of them might take lethal substances like over-the-counter paracetamol, that is dangerous. So that is one factor, one major factor, availability and the change in the trend of the method. That is one factor. The other thing is that impulsive overdose, impulsive deaths. When they are in distress, that they go and take something because they lack capacity to cope with the problem. When the thing is not there at that time, they won't go to that. The other thing is that the mental health issues are now being recognized by many people, especially in the urban sector. So depressions are being detected, and those things are being treated now by the doctors, not only psychiatrists, even the other doctors. So that is one.
There's a greater understanding of mental health amongst
yes.
both the medical community and the public as well.
Yes, but I would say we can be happy about the status, but it has to improve a lot. That's why we have to have an open discussion about detection of mental illness and treatment of it, as well as when somebody is in crisis, what to do. Some of them are not mentally ill, but there is a cry for help. So how to deal with that, that has to happen. And destigmatization of the whole thing, and the media. I think that is the main thing that we need to think, because I think probably now the media reporting had been better than compared to the past, because earlier we can see that when somebody dies, it's considered a big thing and glamorized, and the person who has taken the life is considered a hero, and the others are made to feel very guilty. That is the usual scenario. So that might actually lead to a thing called copycat suicides among the similar mentality or similar caliber people. So that has to be stopped, and the dialogue has to be very very open and then ongoing about the ethical and responsible media reporting. Then the other thing, counseling and helping people. So people are now seeking for those things, but it's very important to seek it from the correct person, because if it is from a person who will complicate the matter, so it might be a problem. So you asked about the 4 areas that we have presented. One is about the pesticide and weedicide control and medicinal drug use, rational use of it. Some of the things have to be stopped, and alternatives have to be provided, because we can't just stop. We need to provide alternatives which are environmentally friendly. It's good for the people and also less lethal. Then the other thing is that the use of these pesticides, the farming community, their safety are the most important, and their children's. So there has to be very restricted use, and the educational programs of how to use them, how to store, how to discard them rather than storing. And the other area is about the community care and the young children.
Thank you very much, Professor Kattiaratchi. We'll go into a bit more detail. Just a quick reminder to our viewers as well that there is a network of mental health advocates in Sri Lanka who are ever ready to help you or a loved one whenever you're in a time of need. There is the National Institute of Mental Health, which has a 24-hour toll-free hotline, 1926. There is the CCC line, which is 1333, also open 24 hours. And we have Sri Lanka Sumithrio. Their number is 011-269-6666, and they are operational from 9 a.m. to 8 p.m. If you or a loved one require any kind of help at any time during the day, help is available. Thank you very much, Professor Kattiaratchi. I'd like to move very quickly to Dr. Anula Wijayasundara, consultant physician. Dr. Wijayasundara, when talking about suicide prevention in Sri Lanka, there are, amongst the public at least, there are a lot of contributing factors that are often discussed. Addictive behaviors, alcoholism, etc. How much of a role does contextuality play when it comes to suicides in Sri Lanka?
I was president of the Sri Lanka Medical Association in 2019, and the theme for that year I introduced was facing the challenges and forging ahead for better health outcomes. And among 10 challenges I mentioned, 2 important challenges were reducing the burden of alcohol, tobacco and dangerous drugs in Sri Lanka, and reducing the burden of suicides, apart from reducing the incidence of non-communicable diseases, prevention of road traffic crashes, reducing the burden of AIDS, geriatric problems that we encounter, and prevention of reintroduction of malaria. So I concentrated on these 2, and during that year we had the special expert committee on reducing the incidence of suicides in Sri Lanka. And Professor Samudra was appointed the chairperson of the expert committee, and I think we have been very happy to have been able to complete the book, and which was handed over to the president last week. So I think the most important thing that has led to the reduction of suicides in Sri Lanka, which was highest in the agricultural sector, has been the implementation of the presidential task force introduced by President Chandrika Kumaratunga, where the main finding was, the main outcome was banning the use of 4 potent pesticides, 3,4-DPA, monocotophos, diaminophos and metaminophos. So as a result of that, only we were able to reduce incidence of suicides. In 1995 it was 47 per 100,000, or 25 deaths per day. In 20 years it came down to 10 deaths per day from suicide, and 25 per 100,000. So it was a tremendous reduction. But apart from that, of course, as Samudra mentioned, She mentioned, the destruction of yellow kaneru, and also the drugs that are often used. In the urban sector, we find paracetamol being overused, or over-the-counter drugs. So that has been, I think we are on the correct path, and we need to implement this along with the Ministry of Health. There are certain guidelines have been given, so our task is to implement that. Moving on from there to alcohol and tobacco, actually alcohol is a major health and social problem in this country. We have a per capita consumption of alcohol which is 3.5 liters, which is the highest among the SAARC countries. And if you consider the alcohol consumption for males only, it is 7.5 liters. And in the low socio-economic families, 1/3 of the family income is spent on alcohol. Fortunately, the incidence among women is low, but among men in Sri Lanka, more than 40% have at any time consumed alcohol. So, the list of diseases associated with alcohol is tremendous. The disease directly due to alcohol and the consequences of alcohol is tremendous. And about 18,000 people die as a result of alcohol consumption and related incidents. And smoking, about 20,000 deaths in Sri Lanka per year, and 7 million globally as a result of smoking due to lung cancer, carcinoma of the bladder, ischemic heart disease, and so forth. And you'll be surprised to hear that that the government earns approximately only 140 billion from taxes on tobacco and alcohol, whereas the country spends on diseases due to alcohol and tobacco 209 billion. So that is 209,000 million on diseases related to smoking and alcohol. So so it's these are stark figures, but that is reality.
Dr. Wijayasundara, when speaking about alcohol abuse and alcoholism, and that as a contributing factor in suicide, in incidents of suicide, is there a link that, is there any research that have been conducted?
Yes, actually it has been, Galevela is a town where the highest consumption of alcohol, and many years ago Galevela had the highest rate of suicides in the country. And in the West, the major cause of suicide is depression, but in Sri Lanka the major cause is actual alcoholism. So the work has proved that beyond doubt.
Thank you very much, Dr. Anula Wijayasundara, consultant physician and also former president of the SLMA. I move down to Professor Indika Karunathilaka, the current president of the Sri Lanka Medical Association. Professor Karunathilaka, you've now entrusted this report to the authorities, the president, no less an authority than the president of the country himself. What are you all hoping will be, as the SLMA, what are the outcomes that you all are expecting? What first steps, let's say, would you like to see the president and the government take to combat this?
Yeah. Before getting into your question, let me explain why we wanted to talk about these three topics today. As a Sri Lanka Medical Association, which is the apex body or the premier association for the medical profession in the country, we are concerned about the health of the nation, and we focus on serious health issues that affects the country. And the areas that we have selected today, that's suicides, other one is substance abuse, and the road traffic accident or the crashes. If we take these three areas, even though seemingly unrelated, they are very much related to each other and also affects especially the young people's lives. So that is the most serious thing. That is one reason that we want to take up these three areas together. Another reason is all these are preventable. However, that prevention can only happen through multi-stakeholder involvement. None of these, if you take prevention of road crashes or substance abuse or suicide, only doctors cannot prevent it. Not even health sector. It involves different sectors like medical, non-medical, health, law enforcement, then the statutory bodies, everything coming together. And also all these three areas, general public has a huge role. That is one reason when we handed over the book to His Excellency the President, we want to highlight the need for the multi-stakeholder involvement and the leadership from the top level related to this, and starting with the either a secretariat or a national body which brings together all these different parties and taking action in a coordinated way. So that's applicable for all these three areas. So that was our main recommendation, and that is common not only for the suicide but the other areas that we have mentioned also. So that was our suggestion, and we are happy to mention that His Excellency was very receptive to that suggestion. So we hope it will happen.
Thank you very much, Professor Indika Karunatilaka. Just very quickly before I open the floor to questions as well, you mentioned also as another preventable cause of death in Sri Lanka, which I think, if I'm not mistaken, in our earlier conversation, you said the figure was about 3,000 people a year are killed in road accidents.
I mean,
what are the main causes for Sri Lanka to have such a high incidence of road, and comparative to, let's say, even the region or the rest of the world, is this a very high incidence?
It's a very good question that we have asked, because that will allow us to explain a lot of things. If you go back to those stark figures, say during last 10 years, almost 30,000 people died in Sri Lanka. That's almost like a war. So each year we are talking about 3,000 people dying, mainly young people losing their lives. So that is in addition to those who are permanently disabled or injured. So the damage or the impact that we are talking about is huge and immense. And then other numbers, if we convert these numbers into daily figures, that means every day about 8 people are dying and so many people are getting injured. Once in every 3 hours in this country, someone dies due to road crash. So that shows the impact. And if we convert that into the social impact or the economic impact, that's so immense. And again, you ask what are the causes. Again, if you go back to the figures, now if you go into those numbers, say those 3,000 fatalities, out of those, we may be surprised to hear, out of those, about 1,200 are due to motorcycle accidents. Number one. Number two, three-wheelers, around 350. Then due to lorries, so what you called tipper trucks, again close number. Those are the main reasons. Then comes the private buses and then other vehicles. And lot of people who don't use the vehicles, the pedestrians, lot of people die. So this shows the problem. And if you compare that with the other countries, say even this region, Sri Lanka's case fatality due to road crashes or the number of accidents is highest, even higher than India, even higher than Bangladesh. Again, why? Again, if you go back, the number of vehicles, especially the motorcycles, the ratio in Sri Lanka is even higher than India. The number of trishaws, again the numbers are higher in Sri Lanka. Now we can easily see the reasons.
When you say the numbers, you mean the ratio?
The numbers, the ratios. But again, those ratios tells a story. So that gives the part of the story. But it is not only one reason. I mean, the vehicles and the way people use it, the discipline. I mean, sometimes the unroadworthy vehicles or unvehicle-worthy drivers. So there are a lot of role, a huge role to be played from the community's part. The solution is not easy and the resources are limited. But this is a huge problem that we need to address.
Thank you very much, Professor Indika Karunatilaka, President of the Sri Lanka Medical Association. So let's open the floor for some questions from our sole inquisitor today, Deshan Gronawala. Deshan, over to you.
Thanks, Nadeem, and I think I'm going to pose my first question to anyone from the panel who is willing to come up with an answer. You know, let's start off with the issue of alcohol. I think if you look at it, I think it was mentioned in the first round that the overall consumption rate of alcohol in Sri Lanka is relatively high. If you also look at it on a trend level, it has been increasing, and it's not something that is only relevant to Sri Lanka. It's also something that's relevant to most of South Asia. India, being a country that is culturally similar to Sri Lanka, is also seeing an increase in the rate of alcohol consumption, and you know, it's becoming a trend. So the thing is it that now, as medical authorities and as people who've been in this field for the better part of your careers, do you realistically see an opportunity here to limit or hinder the growth of this trend? or is it that you see the need to make people understand the responsibility that comes with the consumption of alcohol as opposed to try to limit it?
Yes, actually health education is most important. People must be advised from school age onwards about the hazards of alcohol, and actually there must be peer pressure is something that we have to, we have to overcome that. It is people must be made to realize that it is not the trend or the thing to drink alcohol, to be in fashion, to do what your friends are doing. You must know what is right and what is wrong. So the children must be advised about the hazards of alcohol, the consequences of alcoholism, and the deterioration of the mental health, physical health, deterioration of interpersonal relationship, economic and smooth, smooth social interaction. So all the consequences of alcohol dependence should be explained to the children. It is not only the responsibility of school teachers, it is the responsibility of all our religious leaders, community leaders, and all, to see that we can, save the younger generations from the curse of tobacco, alcoholism, and also the dangerous drugs.
Professor Indika, I want to pose this question to you, and I want to ask you the same thing, and I think what Dr. Vijay Sundar mentioned with regard to this awareness. Yeah. But I mean, there are practical issues that do come about. For example, even though peer pressure is seen as something that can ideally be avoided, are you sociable if you don't go out and have a drink? Are you sociable if you don't have a cigarette? These are considerations. As the head of a body yourself, what do you see as the future when it comes to these issues? Is it about managing the problem, or is it about trying to be all end all and we're going to stop it?
Yeah, I suppose managing would be a more realistic goal in the current context. Having said that, the approaches should be multi-pronged. Education is one pathway, and legal enforcement is another pathway, and different regulations, it's important. But more than that, you have mentioned about the prevalence and the usage among the younger population. Mm-hmm. So in that case, I think the empowerment should come within them also, because that is more likely to be more impactful and more effective than education happening or coming from other sources. So therefore, I think it's very important to empower that community and that age group, because change of behavior should start from that point. So schools definitely would play a big role. In addition to that, I think the peer empowerment the community within that age groups, from that age should be starting. Mm-hmm. That should be one pathway.
Professor Katriachi, I think it's another interesting area when it comes to this particular topic about this whole matter about peer pressure and things like that. But one of the, if you look at a Sri Lankan context, very rarely do parents, from everything from addiction to sex education to the tough topics, we tend to shy away from it. And the thing is, if you look at the fact that the rates are increasing, addiction is becoming a bigger problem, we still haven't addressed the issue, and I feel like maybe discourse needs to take place. Do you think the culture we are inculcating is one of suppression rather than actually addressing the issue?
Yes, I totally acknowledge and agree with what you are telling, because our culture, we tend to think that it's not existent, or at least it doesn't exist in our family until it comes to the doorstep. So you don't talk about these things, you don't openly discuss these things with your children. The danger is that, when the whole society, the generation, the peer group that they belong to, if one or two is taking that substance, then probably others won't think it as a normal thing. They won't normalize it. But if 10 or 15 take it, then it becomes normal, or they try to become more powerful and dominate. And the others start to think whether we are doing the correct thing or wrong thing. So I see it as a twofold thing, not only the peer pressure, the availability and lack of awareness go hand in hand. When it's freely available, when people don't know, parents don't know what their children are doing, and they go to the tuition class or whatever, and then probably they get into these peer groups, and then until when they know, it's too late. So probably the awareness that these things can happen to our children, these things can happen to us, has to be thought and talked with the children at an early stage, and these things are there, but not to be victims of it. And the other thing, I think, more than that availability, we as a society, I am really rather conscious about this, becoming it a normal thing in certain peer groups, especially young children, parties and all that. When it becomes very normal, others might feel very difficult to be assertive even. So we need to think about these things and then reduce this availability. And then I think, actually I think that if these are legally prohibited substances, it shouldn't be there in the society.
Dr. Vijayasundara, it's a very interesting point that was raised by Professor Katriarachi, but about awareness. But you see in Sri Lanka, I'm sure you've seen over the years with your experience, whenever there is an opportunity or an initiative taken to initiate a discussion on these topics, on issues that tend to be burning issues in this country, there's always a pushback. One of the, I think, the best examples is there was a controversy around this whole thing about this Hate Ape Pota, which was supposed to be about sexual education, and there was a pushback culturally. So the thing is, you're here advocating for what you believe is the right steps, and you're giving the medical recommendations. But if these are to be applied, and in a practical sense these discussions are to be had, there's always the space, and more often than not it does happen, where the steps you guys take are hindered, and there are, you know, little problems thrown in the way. So the thing is, here we are discussing about the problem, but are we going to be allowed to actually institute the solutions?
I know the controversy about introduction of sex education. So, well, that is, well, there was a lot of discussion, I think, in many TV channels about it. But I think from traditional point of view, I think our society at this point of time is not geared, you know, for that type of education at present.
This is why I'm asking you, when it comes to this particular topic also, if in schools teachers want to talk about drugs, if in schools people wanted to talk about alcohol, if in schools they wanted to say, like, this is what will happen at parties, this is what your peers are, seniors are doing, this is what you need to be careful about, will there not be the same pushback? Because you yourself, you're saying that the culture is not ready to have these discussions. So why is it okay to talk about one taboo, but it's not okay to talk about another?
Well, that's different, isn't it? While, I mean, there's no argument about the dangers and health consequences of smoking, tobacco, alcohol, and dangerous drugs. That's quite different, isn't it? I mean, those are taboo. They are addictive, psychoactive, and definitely cause harm.
Yet there is reservations about talking about these things in schools.
No, there is no reservation about talking about alcohol, tobacco, and dangerous drugs. But there may be reservations about sex education. So that's it. I mean, but children must be made aware at schools and at any level. Actually, families must talk about it. Schools must talk about it. But making them aware of tobacco, alcohol, and dangerous drugs is quite different from sex education. I'm not saying that there should be no sex education. Well, but I think it is more important to inform, to keep them educated about the consequences of these substance abuse. That is important. Sex education is important, but you know, but I think it's more important to keep them informed about the consequences of you know, these bad consequences of the substance abuse.
Professor Katriarachi, I want to draw your attention to a study which was published in the Journal of Affective Disorders in May 2018. I'll just read a few of the highlights from that study. This is regarding suicide prevention. The study, which included multiple academics and which surveyed over 100,000 people, I think they discovered that the person's environment influences the suicide risk. They also acknowledge that there is a major lack of quantitative studies from Asia which investigates contextual factors when it comes to suicide prevention. They also note that suicide risk in rural Sri Lanka is associated with low community and household socio-economic position. community problem alcohol use increases the risk of lifetime suicide attempts, and that women in households with alcohol misuse are at a higher risk of attempted suicide. Are these findings, do they correlate with your own research that has been done?
It resonates with my findings as well, because a lot of research had been done on methods, and then after what happens afterwards and all that, and the genders and statistics and all, but not much on socio-cultural aspects. But what you said is, yes, that if you can remember the Mahaveli resettlement time, that people went there as families and then settled there, and then there was a sudden rise of suicides in these areas. One was availability for sure, but the other factor was that these families were dislocated from their social background, the support that they had in their families, the leadership, the structure, all that were disrupted. And when they went into a different place, that the leadership was not kind of the one that emerged. It was sudden, imposed, and then the social structure, especially for females, to whom to go to, they didn't have aunts and uncles and friends, they were not there. So when there's crisis and when there's available substance to resort to in impulsive act, they go for that, especially the youth. So the suicide rates rose, and there's a socio-cultural connotation to that.
Amongst which age and gender groups is suicide most prevalent?
Now it's alarming fact that we have this elderly males and young females. In the recent statistics that they show that the young females between 21 to 25 and also the elderly males. So probably again, we haven't done research on it, but I can, with my experience and then reading about the other countries and all, that there could be, and what Indika said about the alcohol and drug use in this country may be having a big influence on the suicide rate as well as the road traffic accidents as well. Because maybe that the elderly are loneliness, and then they being vulnerable, and then especially the males, their role in the society is not there, and some of them may resort to alcohol, or they may be abused by alcoholic sons or son-in-laws or daughters. And then when it comes to females, that they may be battered at home, and young families and without much means of supporting themselves, and they are very, very vulnerable. So we need to think, I mean, all these things are interconnected. So this drug and alcohol use, and then inability to cope in crisis, and in this modern society, the lack of social support and changing social roles, and the elderly losing their status in the family or the village, and both parents are working, and then the money is going for other things. The money is going for the alcohol, drugs, and for other things, transport and daycare or looking after children, and the whole or the migration to earn.
We've also seen several media reports in the recent past of when it comes to suicide amongst students, school-going students. Students have been committing suicide over things like exam results. Is this just something that we perceive because it is quite prominently featured in the media, or is it an actual trend?
What I see is the usual trend now, that because of the examination and education structure, especially a group of parents and the schools, they drive children to study and do well at the exams. Fair enough that they know that their children can go into a place if they pass the A-level exam, O-level exam, O-level and A-level, and that's a real bar exam. So they push their children to study. So what happens is that this child is from the small days. I have seen families, especially mothers, they do everything, feed the child, wash clothes, don't allow the child to play with the others, and this is very, very important. This is connected to what Anula said as well. So they go through these changes in adolescence during the period of between 12 and 18.
During puberty.
Puberty, yes, and then adolescence is the time that the change. So what happens is that in earlier era that we were in caves, possibly that they were free to go with their emotions, and then their their feelings. But now what happens is that this age, this prime age, that they are struggling with the emotions, which are natural, sexual feelings that they are struggling with, and then they are supposed to go to tuition classes and then interact with them, but they are not supposed to speak to them. They don't know how to deal with their feelings, and they don't know what to do. And along with the rebelliousness which happens naturally during the adolescence, they tend to experiment, and if they are not talked about these things, the dangers, and then what might happen to them, and all that had not been taught. All they were told is not to do, not to talk, not to, and it's suppression. But openly not discussed, but they don't know what to do with their feelings. So some of them becomes guilty, and they might become depressed, or they lose their concentration. Then again more pressure, and then some of...
Just to summarize it, I think it's, am I correct in saying that what you're saying is that when there is that kind of suppression, that the reaction comes out in negative ways?
Different ways. I think I would rather don't look at only on children. Health education or sex education or talk about alcohol and drugs with children is not, it's isolated. We need to look at three groups: children, parents, schools. And teachers are very sensitive to talk about these things. Teachers are shy to talk about these things in a professional or in a very professional manner. But parents are the same, and the children, they don't know. They go to the peers, they go to the tabloids, they go to the social media. Now they learn wrong things. They think which is right is actually wrong. So they go with that because of the curiosity coming with the age, and also coming with the peer pressure and all that. So these things we have to, like, culturally sensitive ways we need to identify without going against culture.
These topics.
Yeah, on these sensitive topics. When talking with children, it should be about how to understand these feelings, how to cope with stress in a positive manner, what are the good ways of coping, like sports and debates and then trips or whatever. It's okay to mingle, the discuss and these things, and to encourage those things, not to ask the child to sit and study, don't do this, don't do that, and then the child doesn't know what to do with. So it should be more rounded person has to come out, and the parent should be more receptive, and then they should allow the person to grow. I have seen, being a clinician as well as an academic, so many children face difficulties once they pass A levels only, because when they come to the society, they find it very, very difficult to deal with, because they haven't learned that part.
Nadeem, if I may,
Yes,
I think Professor Karunatilaka, pretty broad-based discussion. I think we're looking at a number of areas that do encompass this very problem. Now, you are the chairman, you are the president of the Sri Lanka Medical Association, and I think, like Professor Katriach just mentioned, you need to have programs in place to, you know, touch on these various segments to maximize your effectiveness. Now you have rising alcoholism, you have a drug problem that I believe even like you said, the president is taking a special interest in combating. You are also having a suicide issue where, you know, certain segments of society you can see alarmingly high rates of suicide. Propaganda like social media, you know, giving a certain message out and not a lot to counter it. You've got your work cut out for yourself.
Very much, exactly.
Where does your institution see yourself as starting? Because there logically can't be the possibility of you covering all these bases in one go. What is okay, forget the complete plan. What's the first step plan that you have in place now that you are the head of this body, in order to kind of mitigate these issues and to actually address them effectively?
Yes, I mean, against multi-pronged. As the apex medical professional body, we play a huge role related to as an advocacy body, where we discuss with the top level and the authorities. Even the book that we have handed over to His Excellency the President is an example for advocacy work. So that is one area, because we have the access to the expertise. As the Medical Association, we have access to all the top specialty colleges in the country. Therefore, the expertise is there. The evidence is there. Because of that, with our expert committees, we have the capacity to find out the exact knowledge base or the evidence base related to the current issues, the current situation, and recommend action. That is one pathway. Then we have to think about the health professionals and the doctors, because they are the people who will be taking the message to the community. That means empowering and the capacity building, where the continuous professional development comes into play. That's number 2. But I suppose very important, as medical association also, we cannot stay in our ivory towers. True, we play advocacy role. True, we have to develop the doctors, professional development. We have to develop our research base, science base. All that is very correct. But I think we should reach out to the community, because people are the most powerful. And if we want to make changes, here all these areas we are talking about change in behavior, say change in attitudes. When we take, say, behavior in the road, or the substance abuse, or the suicidal behaviors, all these areas we are talking about change in behavior. Change in behavior cannot happen unless we cannot reach out to community. So I suppose as Sri Lanka Medical Association, we have a responsibility to reach out to people, to go to the grassroots level. And during this year also, and in the past several years, we have done a lot of work related to that. And there, we should be able to talk the language that common people will be speaking. We should be able to reach out and convey the message, because community empowerment is so important. Ultimately, the power should come from the people, not from us. We just do the facilitatory role, but the change process should come from the people. Say if you take school children, the voice should actually come from them. Or other categories, say the behaviors and the discipline in the road, again the empowerment should come from the people.
Is there a plan in place, like it's a very valid point you're saying, relatable people coming and advocating for this. Is there a plan in place? Do you have a plan of identifying school level leaders, of identifying leaders within, let's say, the school staff, identifying community leaders, so for example, I think I don't have to explain to you, Sri Lanka has a very strong cultural bias towards their religious leaders. Is there already a plan in place to engage these religious leaders and have them advocate on behalf of these very things? Is there a plan in place at the moment?
It is, I mean, that's one of our key strategies.
Right.
To reach out to the different communities.
Yeah.
For example, at the beginning of this year, we conducted a series of seminars for school children regarding injury prevention. So because during that time, the attitudes and the changes in the behavior should come during that time point. And then we are conducting several community level activities, not only related to the 3 topics that we are talking about, but many areas. We go to the community and meet up with the community stakeholders and leaders and try to start a dialogue with them. Because we strongly believe that unless we go into the grassroots level or the community and talk in a language that would be understood by them, and then they take in the leadership, that's very important. So we are working on many selected areas. The currently COVID situation, we are planning about going to the field and community and empowering them. So these aspects are very important, and we are trying different strategies. And we can't forget the role of technology nowadays, especially the value of social media. We mentioned about social media. So we have taken up social media in a big way to reach out to the communities and convey our messages, because these are the media and these are the modes that people understand. So we have to understand the way they are thinking and address that mindset.
I think also another question that's very important, I think in September 2014, the WHO's first global report on suicide wrongly identified Sri Lanka as ranking. I think you're aware of that. Now, that tells me there is a lack of proper information on the subject. Even for us as Sri Lanka to come and counter them and say, look, this data is wrong. Is there a data-driven approach to understanding the rationale or trying to rationalize why there is high rates of suicide, in what areas this is happening, and what more or less the causes can be? Is there because if if you're looking at trends, which is data, you need to have data in order to mitigate trends as well and to counter trends. Is that data available, or are we still lagging?
Research has been happening during last 10 years or so. The research has been happening, and not only research, getting research into action. For example, certain simple measures that you can take up. For example, Kaneru poisoning. So like that, there were the research have identified what are the modes and what are the causes that has led to suicide, and then there were certain legislations that have taken place. So I would say the research base was there, but there are a lot more work to be done, because now the trends are slowly changing. Like for example, Samudra mentioned, there is the new trend that a lot of elderly people are committing suicide. So it is changing, the trends are changing, but the database is there, database and the research base is there.
Nadeem?
Thank you. Just one more question for Dr. Anula Wijayasundara before we go in for a short commercial break. Dr. Wijayasundara, I was mentioning earlier regarding a study from the Journal of Affective Disorders on attempted suicides in the country, and then I've just recovered another article which is actually from the Ceylon Medical Journal, which is published by the Sri Lanka Medical Association, and in this too, it amongst the findings is this high prevalence of incidents of suicides amongst both men and women in households where there is a sort of problem use of what is called a problem use of alcohol, or rather alcoholism, excessive use of alcohol. What kind of steps, what kind of policies can our policymakers take to address these issues? Because on the one hand, I mean, this might sound like a political question, but it is actually, I mean, I intend it as an apolitical question.
Yes.
Because the data, the studies that have been conducted by the SLMA, by international bodies as well, seems to indicate these correlations, these sort of the need for gender-specific interventions.
Actually,
but we do not seem to be giving, in the policy-making discourse, that gender-specific interventions are absent. Case in point being the current absence of a Ministry on Women's and Children's Affairs. What kind of steps should policymakers take to address this?
What is really important is to implement fully, you know, the aims and goals of NATA, or the National Alcohol and Tobacco Authority. The guidelines are there, and what has to be done is in black and white, but unfortunately not being implemented. The most important thing that has led to this, you know, tremendous surge of alcoholism in the country is a ready availability of alcohol in every nook and corner of the country. In one street in Elvitigala Mawatha, actually there are 7 outlets of alcohol, 7 outlets in one street, Elvitigala Mawatha. So the real cause that leads to dependence, alcohol dependence, is easy availability. So one step that has to be taken is to stop giving any new, you know, licenses to open any new liquor outlets, and that it was a fashion in the past for all politicians to give their, you know, their supporters, you know, who support them, to give them, you know, a liquor license. So that culture has to stop. No new liquor licenses should be issued. Secondly, all liquor outlets that are within, according to the law, within 500 meters of any school, place of worship, you cannot have an outlet.
Dr. Wijayasundara, I understand the need to restrict the access to alcohol, yes, as well, but alcoholism is also I suppose it could be classified as a mental health condition, Professor Katayat. So if you deprive access to the substance to which someone is addicted to, won't they just go on to find something else to be addicted to?
But sorry.
Yes.
Research has shown that with the availability, the alcohol consumption of a population would increase. So there is a genetic tendency for some people to go for it more. But when you look at the society, generally, if the availability is more, the people who take more, and the problematic numbers also more. So I think the first step would be to restrict the availability, anything, drugs, alcohol,
as a first step.
As the first measure. And then it's easy to manage the problematic group as well, and the accidents, violence, all that, the other related issues and the social problems, children's issues, all that will go down. Then the real needy people who need the addicted or who are really medically unfit can handle, because the numbers are small. But if you look at the figures, like if in a society, if the numbers of people taking alcohol is 4%, easy to handle. But if it is 40%, it's difficult. If it is 70%, you can't. Then the other rest 30 also become alcoholic. So we have to look at numbers.
Dr. Wijayasundara, you mentioned the National Alcohol and Tobacco Authority, the NATA, that there were guidelines and that there's a strategy in place to combat this?
Yes. So first was it, and other things also to reduce the number of hours and days that alcohol is available. To close all outlets by, around about 11 or 12. And to increase the age, where tobacco can be smoked and alcohol consumed, to above 18 years. I think should be even increased to 21 years. So those are, and also it's very important, to have proper taxation on these products. That is, every year, the Sri Lanka Medical Association, especially our expert committee on alcohol, tobacco and dangerous drugs, writes to the Ministry of Finance to have proper taxation on tobacco and alcohol. And actually it is
what you mean by proper taxation? Higher taxation.
Higher taxation. And in fact, it is a taxation on alcohol, on tobacco, that has reduced, and with that, the price of cigarette is now, the cheapest cigarette is about 55 rupees to 60 rupees. And with that, there has been a definite reduction in consumption, in smoking cigarettes.
Dr. Wijayasundara, there is a public perception that, and we've heard this many times from many people as well, is that when you increase the taxes on, let's say, the cheapest and most likely to be abused types of spirits, let's say.
That is what the tobacco company says, and what the alcohol company says, but the
people start consuming things like moonshine.
But actually, that is what the tobacco companies and what the alcohol companies say. But it has not been shown. Studies have not shown that with increasing, the price of alcohol, that there will be a rise in
illicit liquor.
Rise of illicit alcohol. So that is what the companies say. But work has not actually proved that.
Thank you very much, Dr. Wijayasundara. On that note, we'll go in for a short commercial break. This turned out to be a very engaging and informative discussion. Stay with Face the Nation. We'll be right back. Welcome back to Face the Nation. If you're just joining us, we're taking a departure from politics this week, and we're discussing three very important subjects in the country today. We're talking about suicide prevention, alcohol, tobacco and drug abuse, and also about the road traffic incidents. One of the reasons that we're talking about these topics today is that self-harm is actually the fourth leading cause of death in the country, was the fourth leading cause of death in the country as of 2017. Road traffic accidents followed not too far behind at number 9. And we're also looking at the contributory effects that alcohol, tobacco and drug abuse has, not just in terms of road accidents, but also in terms of suicide prevention. If you're just joining us, also a reminder that if you or any loved one is facing any kind of problem and requires counseling or assistance, there is a network of mental health advocates in the country that are available to you. The National Institute of Mental Health has a 24-hour toll-free hotline, which is 1926. There is the CCC line, which is also a 24-hour hotline, which is 1333. And there is Sri Lanka Sumithrio, the Sri Lanka Sumithrio organization. Their number is 011 269 6666, and they operate from 9 a.m. to 8 p.m. So we're in discussion today with Professor Indika Karunatilaka, the president of the Sri Lanka Medical Association. We're also talking to Dr. Anula Vijay Sundara, consultant physician and a former president of the SLMA as well, I think immediate past president, if I'm not mistaken. And we're also joined by Professor Samudra Katriarachchi, who is the chairperson of the Suicide Prevention Committee of the Sri Lanka Medical Association. Professor Katriarachchi, when I left off, I was referring to this article that appeared in the Ceylon Medical Journal, which is authored by T.N. Rajapaksa and S.U.B. Tennakoon of the Department of Psychiatry and Community Medicine, University of Peradeniya. So in this, we're talking about gender-specific interventions when it comes to tackling, when it comes to sort of supporting suicide prevention. They write in the article that it is necessary to examine in depth the socio-cultural as well as possible psychological factors associated with suicide in young women in Sri Lanka. They talk about this idealized protected female role, the changing gender roles, and how younger females may perceive relatively less ways of communicating their distress or protest, especially in a hierarchical culture where overt confrontation is frowned upon or stigmatized. You mentioned early on in the show that prevalence of suicide in Sri Lanka right now, while it is much lower than what it used to be in the mid-90s, is still quite high comparative to the world at 14.6 per 100,000. Do you agree with the findings of Mr. Rajapaksa and Mr. Tennakoon in this case, where they talk about difficulties in communicating distress and protest, and they attribute it to the hierarchical culture?
Yes, and then we talked about suicide rates in the country and the world, but we didn't talk about the self-harm and the distress level. So by reducing the availability of lethal substances, suicide rate came down. It doesn't say that the problems people had or the coping mechanisms or the support mechanisms are in abundance and then people are facing problems well. Actually, it's the other way around. So the people are now, there's a slight rise in, not slight, rise in self-harm admission, we wouldn't call it attempted suicide because some of them don't want to die. Actually, it's self-harm. Some of them want to die, some of them it's a way of communicating distress. So they don't know how to communicate distress, and they communicate distress by harming themselves. So that is the only thing people hear or listen to. Because always, as you mentioned, the suppression and all these things are there. And if you look at the Asian or even developing countries, even depression, they don't come and tell, doctor, I'm depressed. They will come and say, headache, papuri, heartburn and all that with somatic symptoms, and actually somatic symptoms due to gastritis or muscle tension and all these things. The same way, they are unable to tell their distress because nobody listens, nobody takes them seriously. So one way of communicating their distress is that doing harm to self, so that everybody will get together, and then now what has happened and all that, all the attention is there. So looking at gender specific issues, yes, there are not only gender, there are specific vulnerable groups. So one is gender, the young females, where the social network is not enough for them to talk about their distress, because if you talk about this distress, especially married, and I have to tell that it's married women who also, especially the young married women and who are bearing children also, pregnant women tend to die. So because probably if they talk about these things, it's not good for the family, it's stigma, so they can't talk. And we have to tell, if you tell somebody that, they will talk about it in a different way, so they don't know how to whom to tell. And then even if you tell that, what happens, nobody takes it seriously. I had been doing this police training, especially mainly for Women and Children's Bureau and all, and one of the ladies, one of the questions that I asked, that if a woman comes in the night in distress and tell you that I am having problems at my family, what would you do? So usual response is that you try to patch it up and then go. So then I ask the question that if a person, do you think that if that person comes to you easily in the middle of the night, by not bypassing, she has exhausted all the other resources when come to that point. So if you also say that go and try to do something and then look after your husband and stay, where else she can go? So probably that is the end point, that she takes poison. Same with the hospital, that when you come to the hospital, that the doctors and nurses, if they are not sympathetic or empathetic, and if you say that this person has taken poison or Wahabi, they feel very embarrassed, and then there's no way where to go to help. If you go to religious institution, again you get the cultural connotation, and then you say that, oh, ahommatamai, that you have to get adapted, and it's the nature. So this whole cultural setup is stopping person speaking, and then this person doesn't know what to do, and at the end of the tether, that they might take their lives. So we have to open it up now, and gender, children, young adults, elder abuse is more, especially with the family members, and these things have to be spoken in a very culturally sensitive and open and close to heart conversation. And whenever I go on talking about these things with many people like police officers, they become very emotional, they understand what is not correct, and they like to change. Because not that they do it intentionally, because of the culture, because of the way, because of the environment, yes, they are okay. So that we have to change this culture. We have to change at every level, doctors, nurses, teachers, parents, every level, that the reception of the distress and approaching this distress in a positive manner. Then if you can't handle that, and if the person is more suicidal or more in distress, then go to, I wouldn't say counselor, because the counseling is not regulated in this country. So might as well go to a trusted person with professional skills and then talk about it. If not, then go to a reputed counselor, not the ones that who have half training, that they might do various dangerous things. So properly trained person from a university or some organization, then go to that, or then you can go to a doctor. Now, because now in all the universities in Sri Lanka, they train in mental health. They get proper training as a final year subject, and suicide assessment and counseling skills and all that they get. So many of them have training, not all, I wouldn't say everybody, but they would understand. And whatever the help that you have to access it, and then get that help and talk about it. And then that the person who is talking should not take it as a story or way that it's not to glamorize it or not to stigmatize the person, but to help appropriately, be a shoulder to cry. Not to give advice as such. So this culture has to be changed. So that's what we are proposing under the community chapter here, the seven things that we have proposed at every level: community empowerment, training of gatekeepers, training of primary health care staff, school-based interventions, counselor training, all that is there. So what we propose is that over the years we have realized that we cannot do it via health sector. We cannot do it alone. The teachers and counselors, and they can't do it alone, because they are...
It has to be a multi-sectoral approach.
It has to be well coordinated, well coordinated act, and everybody should take the responsibility, especially the community empowerment, and it's not one person can do it. So we have
and there has to be political leadership as well.
Yes, it should be coming from the community, and then the leadership should emerge, and then we have to work in collaboration, respect everyone's capability. They can do a lot. They can do a lot if we give them the know-how. So it's very easy.
Actually, on that note, Dr. Arunala Wijayasundara, I'd like to come to you, given your experience as a past president of the Medical Association as well. I mean, I see even a cursory search on the internet, and there is a wealth of information regarding these topics that we've been discussing, from the Ceylon Medical Journal, from international peer-reviewed publications as well, that talk about these issues they go into some degree into the context, preventing these things, even on alcoholism and alcohol abuse, even on restricting access or reducing the availability, and it makes me wonder, over the past several decades, if all of the research and all of the work has been put in to develop guidelines. You mentioned the NATA guidelines. There's multiple articles on suicide prevention, on alcohol, tobacco and drug abuse. What I sort of cannot comprehend is why policymakers, the legislators, have not taken these into consideration when drafting laws, when deciding national action plans and national strategies.
Well, as has been mentioned earlier, multi-stakeholder is very important, but to have any program or project, to be implemented completely, there must be a lot of political will and determination. So I think a case in point at present is the all-out drive against the underworld. So that has a lot of political will, political backing, and a lot of stakeholder participation. And I think that is being implemented very successfully. So I think that is a case in point. As now today's newspaper said that 6,000 people have been jailed for drug-related crimes, and that it is estimated that there are over 600,000 drug users in this country. So that is going in full gear. But so I think so. It is hope that not only the small fry, but all the big people who are involved will also be, arrested soon. And also the maximum punishment must be given so that people will be afraid. And as has been mentioned, all the property, movable and immovable, should be confiscated. And the most severe punishment must be dealt to these people, who are dealing with drugs. So similarly, so there is an all-out war against this drugs. So similarly, tobacco. There has been a lot of work done on tobacco control, and especially the plain packaging and the graphic designs covering 70%, and the taxation, which even more than what the WHO has recommended. So that has definitely led to a reduction in tobacco smoking in this country, which is now about 33%, and among females it's even less than 0.5%. So there has been definite reduction in smoking, right? And especially professional classes don't smoke. It is only the low-income people, and where they are smoking also adds to their to their health problems, and also exacerbates poverty. So there has been definite decline in smoking, and drug control is in order. So of course we hope that it will be more extensive, more arrests will be made, and more people will be apprehended. But where unfortunately where alcohol is concerned, partly because of lack of implementation of the NATA proposals, and also probably lack of awareness, lack of or just people do not fail to, or they do not want to understand, or it is thought is a social norm, whereas there is no doubt about the fact that dangerous drugs, there is social taboo to it. But where alcohol is concerned, there is no social taboo. It is considered as an accepted norm, in this country. For parties or for any banquet, it is considered as a norm to have alcohol. But when I was president of the Sri Lanka Medical Association and also president of the Ceylon College of Physicians, like me, there were many others who did not serve alcohol at all at any academic function. So if you have to accept new norms, so I think that is very important.
Professor Indika Karunatilaka, actually along the same lines, a question to you. The research and all of the contributions from academia is there, but even adding to what Dr. Anula Vijayasundara was saying as well, going beyond controlling the access and availability, addressing the contextual problems that and the cultural problems that are being raised in a lot of these papers. Why is it that there seems to be a mismatch between the policy direction that is taken by the political authorities and what is being reflected as the ground realities in academic papers and studies?
Yeah, I mean, the very reason that you asked that question, that shows the topics that we have selected and the message that we wanted to give has succeeded. Basically what we want to show was how challenging it is. Those three very important areas which are interconnected, everyone knows they are important. Everyone knows that they are issues and everyone accepts that they need to be addressed. The very question that you and Deshan asked shows us how challenging addressing these. If you take the suicide part, we are talking about a huge socio-cultural stigma and taboo. And if you take the drug and alcohol abuse, substance abuse, again we are talking about acting against a multi-million-dollar industry, maybe legal, maybe illegal. And road traffic, again we are talking about a system which cannot implement, even though law enforcement tries, the resources are so limited. And the road network, all this investment that has to be made is so huge. And the cultural changes, road behavior, all these changes, it's so difficult to make. So again, this is why from the beginning we said, all these calls for multi-pronged action, the top-down as well as the bottom-up. The top-down level involvement, decision-making, taking tough decisions is essential. That's why the advocacy role and reaching to the top decision makers is very important. Again, the bottom-up, very important. We need to reach the community, empower the community, because the voice should come from them. And not one profession can do it. That's why we are talking about multi-stakeholder involvement and a concerted approach. The time has shown that one entity or one profession cannot do that. It's not possible. That's why we wanted to go for, we want to work with all the stakeholders, work together and go for a concerted approach. In that way, hopefully we should be able to
align the research with the policy.
Yeah, and I think we should not be giving up. It has to be the perseverance. Perseverance will pay off as time goes on. Now if we think about, say, tobacco and alcohol, about 20 years ago smoking was fashionable, but with social marketing, empowerment, it's not so. So contexts are changing, and if the perseverance are there, I suppose we can do it, and if we work together, it's definitely possible.
Thank you, Professor Karunatilaka. Deshan, yes.
Now, if I may, Professor Karunatilaka, I want to ask you a pretty pertinent question, and I'm going to ask you this question since you are now the head of the body. You know, these discussions about improving awareness, about increasing know-how, about getting involvement from all these parties. You know, it has been a matter that has been at the forefront when it comes to mental health professionals and the mental health sector, that there are these issues. They have been identified. But if you look at it, progress has been terribly slow. And while incremental progress tends to be slow, the adverse effects or the networks that are working to actually dismantle the good work you guys are doing tend to operate much faster. So the thing is, how is it that the authorities, that being you, being the government, being law enforcement, tangibly measure and ensure that, look, there is a plan, and here we are following the plan and actually getting closer to the objective? Is there, and I think especially the President is very serious on this whole matter of KPIs when it comes to even state enterprises. What are the indicators you as a medical body look at when it comes to, let's say in 5 years, saying we have improved on achieving the objectives we have set out to achieve?
Yeah, I mean, in these kind of activities or initiatives, it takes time.
Yeah.
So as I have mentioned, perseverance is the most important aspect.
Yeah.
So as an organizational point of view, we have our corporate plan and the objectives in place. So whoever the president comes, we have our objectives related to the advocacy body and relating those priority health areas. So that's going to continue.
Yeah.
That's one aspect. And in my experience working with different stakeholders, for example, related to prevention of road crashes, what we are working is actually a body of different professionals and stakeholders, and they come from different angles and come out with different suggestions. And when we discuss with them, actually we see things are happening. For example, police, what they are doing. outwardly it might not be visible. But when we discuss with them in these committees, they mention about different steps that they are taking. For example, using, say, officers in civil clothing in public transport, so then they can identify the measures or whatever the wrong things that they are doing. So things are happening. I think at the moment what we can take are the process indicators. What are the steps that are taken? Sometimes small steps matter. For example, labeling in the plain packaging of cigarettes, small steps, or destroying, say, yellow oleander. Those kind of small steps, which is based on research. So I think we are on the correct pathway, slowly developing an evidence-based, and then advocating the necessary authorities. And very importantly, we are connecting up with different stakeholders. We are liaising with police, law enforcement, lawyers, or the general public, or the corporate sector, working together. I think that pathway has to be continued. We might not be able to see immediate results, but with time, I think we can make a change.
Dr. Vijayasundara, from your experience, what are the areas apart from, well, the most obvious ones in terms of looking at things like, you know, the rate of how many people tend to consume alcohol, like, you know, when you get the per capita consumption, things like that give you an indication of this is where the trend is going. What are the social aspects or the subtle markers that tend to give you an idea?
The social consequence of alcoholism, you know, like, you know, sexual abuse, you know, wife battering, child battering, suicides. Those are all, you know, the social depression, anxiety, stress. All those are psychiatric consequences of alcoholism. Pathological jealousy, impotence. Those are consequences. As you know, some alcoholics become impotent and they become pathological jealous of their wives. In high incidence of suicide. You know, all these are psychiatric manifestations of alcoholism: depression, anxiety, pathological jealousy, depression, and suicide. So those are consequences, psychiatric consequences of alcoholism. The social consequences, you know, violence in society, sexual abuse of women and children, right? Then what about murder? You will probably recall when, you know, a very highly respected judge, Sarath Ambepitiya, he was one of the judges who took a strong, you know, view against drug abuse, and, you know, gave a verdict, you know, against a famous drug trafficker. And the chap who was hired to kill him, he just consumed a bottle of arak before he went to do it. He just got Dutch courage to do that. So you see, so those are the consequences of alcoholism: social consequences, health consequences, psychiatric manifestations, loss of social standing, economic deterioration, lack of relationships, proper relationship with the wife and with the children, lack of harmony in the home. So I mean, it's
is this not broad? Is this not broad based?
Picture.
If you look at it, let's say you take a look at this problem from afar without being as involved. A lot of the issues that you mentioned tend to also have a significant amount to do with the state of the economy of that particular familial unit.
yes.
Do you, from your experience, do you think contributing towards economic growth or a slightly more financial freedoms, say, that a family can possibly be given, will actually help in solving some of the problems that you were mentioning?
It is well known fact that alcoholism aggravates poverty, and in particular low socioeconomic families, more than 1/3 of the family income is spent on alcohol and tobacco. And in fact, much of the Samudri contributions that are given to people is just spent on alcohol and tobacco. So it is just to drain on the country's wealth. It is just, Samudri is given to alleviate poverty, but what happens? Some of the money is spent on alcohol and tobacco. So it's just money down the drain. It
Absolutely.
is well known that poverty is exacerbated by alcohol and tobacco.
Absolutely.
And drugs.
Now, another thing I think I'm going to ask Professor Katriyaj this. See, a lot of this education, as we mentioned earlier, comes, let's say, at a later stage in life. But very little of this do you see incorporated into the syllabuses of school children. And I'm sure Professor Karunatilaka will agree with me when I say that the updating of these syllabuses has also been found wanting. I think, as far as I'm aware, the President has mentioned that he wants to look into this as well. Now, why is it that these important considerations, these social issues, aren't incorporated into the education of children? And why is it that these are often left to be discussions to be had elsewhere? For example, slightly deviating from the particular issue when it comes to alcoholism and drugs, we have very little education on finances and financial management. We have very little education on taxes. We have very little education on how to get a driver's license or how to change a tire. So the education is quite outdated in this country, I would think. Why is it that issues like this that have been pertinent issues for decades not incorporated into the education system?
I see it as that we don't have to overload the curriculum.
Just to interrupt before you answer the question, why I ask you this is because all three of you have, for the better part of this program, been saying how important an aspect education is.
Yes.
And if the education that is required to actually stop these issues from coming up and from, you know, constantly being a problem for our society, and if the parents are not giving the education and society is not going to teach you, somebody does. And usually it's the authorities that need to help do that.
It's mainly, I think, due to the academic pressure on the system, on the whole system, the parents, teachers and children, and everything is driven to examinations. So I wouldn't like going and overloading them again with finance management and stress handling and all that, but I would rather prefer giving them more freedom to do teamwork, and then like developing children should develop it in natural settings like sport, debates, various societies.
Let's narrow this down to the problem at hand. Let's narrow this down to the issues of alcoholism and drug abuse and using excess amounts of tobacco. You know, and I think you know, my parents come from a village as well, from outstation, and all of you know, something that I hear constantly is that මේ කට්ටියව ක්‍රීඩාවකට යොමු කරොත් මේ කට්ටියට සිගරට් බොන්න අරක්කු බොන්න වෙලා නැහැ. You know, it's a very basic way of looking at it. But we don't incorporate, we tell our kids, look, it's not good for you to drink, it's not good for you to smoke, but very rarely does that incorporate, you know, this is what will happen if you smoke, so you have to be smart enough to choose, or these are the negatives of alcohol, you know, that kind of thing.
Yeah, the problem is that along with the sports, we know that the market is also targeting them.
Yeah.
So it's no point sending them to sports unarmed. So these things have to be talked and then discussed. Yeah. But before that, the teachers and the parents should know that this market is there and they are targeting at their children. Mm-hmm. And then we are sending it with a different view, like developing their personality and then the teamwork and all that. But something else might happen. And that's also people, even the parents send them not to learn those things. They send to win the game, being the first. So those attitudes, I think, have to handle rather than curriculum, not through a curriculum, but by education of the more parent-teacher interactions and more experts and interacting with the teachers and then with the parents and the children. So again, community empowerment should come in, but I understand what you ask, but it should be looked at not as a curriculum overload, but in a very more subtle way, like again through the policies, I guess. Mm-hmm. Policies that it should go to the school principal, that these things, how to handle these things, and to develop a policy in your school, how to handle these issues, and then let them come up with and then measure that. Mm-hmm. The number of people get addicted or children who default.
Professor Kathiarachi, just because I'm sorry to interrupt you, but just because we're running out of time, just one final question to you before we wrap up tonight's program. You've submitted this book. I hope the book will be made publicly available as well soon. You've now submitted it to His Excellency the President. As a first step, what would you like, now that you've given the book, what would you like to see the political authorities do as a first step?
as a first step, I would like a stakeholder discussion with His Excellency, and then all the stakeholders mentioned in this book have a broad discussion and have a develop an authority with some meaningful action plan, and then implement this as well as the other things. So coordinating authority would be the first step, but before that it should like after a discussion and then to come up with the coordinating authority with multi-stakeholder participation, like a child protection authority. Yeah.
Eventually leading up to something like a national action plan across all of these.
Yes, that's what I would like to happen, and in 5 years time I envisage that's a success and happy nation. It coupled with the economic and other developmental things as well, but if the mindset also has to be coupled with that to enjoy the other areas. So
thank you very much, Professor Samudra Khatriarachi, Chairperson of the Suicide Prevention Committee at the Sri Lanka Medical Association. Thank you also to Dr. Anula Wijayasundara, Consultant Physician and immediate past President of the Sri Lanka Medical Association, and Professor Indika Karunatilaka, the President of the the current President of the Sri Lanka Medical Association. I wish you all success in this endeavor to align policy making and academia, so for the betterment of the country and its people. We've had some heavy discussion tonight around three very sensitive, one very sensitive issues, a contributing issue, and also about, so we're talking about suicide prevention, drug, tobacco and alcohol abuse or alcoholism, and we were also talking about the high prevalence of road traffic incidents in Sri Lanka. Two of these, self-harm and road traffic incidents, are among the top 10 leading causes of death in the country, and these are preventable deaths which as a society we should act to prevent. A quick reminder to our viewers who are watching at home as well, if you or any loved one is ever in need of any kind of assistance, there is a network of mental health advocates that you can reach out to, including the National Institute of Mental Health. Their 24-hour toll-free hotline is 1296. There is the CCC line, which is also open 24 hours, which is also accessible 24 hours, which is 1333, and there is also the Sri Lanka Sumitra organization, the number just coming up on your screen right now. We usually end our Face the Nation programs with a quotable quote that has some relation to the topic at discussion. Given that we've been talking about some very serious issues today, I'd actually like to end with an extract from a book by the writer Emma Rose Krauss. It's called The Blue One. So ask me if I'm all right. I'm fine. I'm always fine. You see this look in my eyes. No, I'm fine. I am always fine. There is a corpse behind my smile. Listen, I am fine. Always, always fine as fine can be. Are you okay? I am more than okay. I am more than fine. I am wonderful. These are issues that need to be taken very seriously. We hope that you found tonight's discussion both informative and enlightening. Good night and good luck.